We're going to start the second part of the program now, and it's really Dr. Cather who's going to kind of shepherd the whole thing through. If somebody has seen a set of eyeglasses, it would help her to actually see anything, but she'll manage, she says. Dr. Cather is our chief psychologist in the schizophrenia program. So this is an example of interdisciplinary work. You know, I'm an MD, she's a PhD, and we've worked together actually for 20 years, a long time. She has really made, I think she's trying out different glasses now from random people. And I think she has made an enormous difference for, me professionally, appreciating that not everything is medicine. There's another really important part in treating patients with psychological illnesses, which is, by actually talking to them. But she's also always been at the forefront of research, how to effectively actually talk with people. So cognitive behavioral therapy, resilience training. On the other hand, also has worked, how to get people better medically. For example, how to help them quit smoking. So it's not just, taking a medicine to quit smoking, but also having the groups and everything that comes with it. And she has actually received a very exciting grant that you'll describe a little bit through the state for all the work that he has done on what we call the psychosocial realm of things. I always say medicine is only 20%, important 20%, but everything else is 80%, in almost any illness. And so Cori represents really this important 80%. Now I'm building you up real high here, okay? But I'm looking forward to what you have to say, and she's going to also, let's welcome her and thank her also for putting together the patient panel again.
Thank you so much, Oliver. And I can't say enough about what it's like to work with such wonderful colleagues. We all try to help each other. And even though, this DMH grant is something that I happen to be the director of, it would not have happened without people like Daphne and Oliver doing the work that they've done that really made us competitive for something like this. So it's a true collaboration. So I'm going to tell you a little bit about this new grant that we got and what it enabled us to do, and it allowed us to create a center. And whenever I go to these talks where I hear about centers, I'm like, well, what does that mean? Can I go there? Can I get something there? It's not actually that kind of a center. It's a center of people coming together to do research and to think about training and to think about elevating the level of care that's provided in the state of Massachusetts, and to think about how we can work better with communities in the spirit of this talk today about how we can work more in community structures. So our name is really long, and if anyone has any good ideas, we certainly would welcome them. A catchy little acronym would be wonderful. So we are the Center for Psychosocial Research, Center of Excellence in Psychosocial and Systemic Research. So what is psychosocial research? Well, Dr. Freudenreich set that up really nicely. So this is the sort of the non-medication research, but it is often adjunctive to medication. In fact, in schizophrenia, ideally almost always adjunctive to medication. So these are the things that we do that work on smoking cessation or think about things like positive psychology improvements, etc. Systemic research is more about how do you change systems. For example, one of the things that we started doing at Mass General wide in fairly recent years was documenting smoking status that was not documented in the medical record in a very clear systemic way. And you can see that a change like that is system-wide could then result in other changes that come down the road. So this center was a collaboration really between the MGH schizophrenia program and the Division of Public and Community Psychiatry. Mass General is this funny place where we have these different programs, like we have a schizophrenia program, a bipolar program, a depression program, but there are many people who cross-share interests, and so we're this funny matrix. You might be in one program, but you might share common interests with a lot of other people about public health, about decreasing the stigma of mental illness, those kinds of things. And so it's this partnership of people who essentially share interests. Right now we have funding for 3 years. We're in our second year. And the goal of this grant was really to move the needle in the Commonwealth of Massachusetts in terms of people who have psychiatric illness, also as well people at risk. And to think about things like involving family members more in care, and to think about physical health and the things that that we have a strong track record of working on. We also really thought a lot about thinking about healthcare disparities. I mean, when you think about SMI, serious mental illness, that is a healthcare disparity already. People are getting different levels of care. And we see within that there are other groups, homeless people with SMI, who are even getting potentially less access. So we wanted to be really sensitive to that, to people who were from ethnic minorities, that kind of thing. This is the mission statement. You can read it. You have it in your flyer. The other thing that we're interested in doing is developing some community partnerships. Daphne's work is a good example of this, where she has created a partnership with the pediatrics practice in Chelsea at MGH Chelsea. So there was an identified need for doing more for their mostly Latinx community, and they sort of are interested in having us come in and do this. So it's not like we get a grant without talking to any community agency, and then we kind of shop around and say, like, would you want to do this with us? It's more flowing from the community agencies to us as an interest. We're really interested, too, in thinking about how can people with lived experience be a resource and inform our efforts and be, co-staff with us on these different endeavors and research projects. A lot of research these days is talking more about the gap between science to practice. And many of the things that we're trying to do is to close that gap. So there's often like a 17-year gap between the time that something gets found to be effective and the time it becomes available actually in the community. And sometimes there are things that we know are effective that never get implemented in the community. And we're trying to change that, and we're trying to think about one way of doing that is to inform more people who are either the target recipients of this to advocate for these programs or services to be available for themselves. We also really wanted to make sure we had the right stakeholders kind of at the table. So one of the very exciting people that we have in our group now is actually a representative from Mass Health who talks to us about things like, what is Mass Health willing to pay for, or what are they thinking about paying for? And when we talk to her about things that we think they should be paying for, it sounds like she's listening to us. So it's really been very useful. The other thing we sort of notice, and this is again this big gap in implementation, is that we are terrible at disseminating information. Actually this Mass Health person was talking to me the other day, and she said, one of the things we're not doing a good job on is educating people, what does good treatment look like? What does good therapy look like? How would a consumer even know how to evaluate if they're getting good therapy? And you can think that people who have lower literacy in, always, but maybe in terms of this kind of mental health knowledge, may be getting taken advantage of. They may be getting something that they're paying for, or their insurance is paying for, that isn't the best practice, or is ignoring something that is very well known to help for a particular condition. And this can certainly happen with medication as well as with therapies. So we're really looking at thinking about how can we get more information out to people? How can we teach people more? We also have the goal of developing research that helps new investigators, junior investigators, and you're going to hear from someone later today, Julia Brown, who's one of our postdoctoral fellows, obtain her own funding to do things. And that sometimes requires, some of these community partnerships, but it also may require some more academic, traditional sort of work, because it's hard to make progress sometimes on an academic track when you're only doing community work. So we serve multiple masters. what did we do in the first year? So we got this grant in October of 2018. We hired 25 people, including 7 people with lived experience of mental health challenges. We went out and conducted listening groups across Massachusetts. My colleagues, Ann Whitman and Jackie Martinez and Sandy Whitney-Sarles, are going to present that together with Hannah Skeist, who is the research coordinator on that project. And that was the idea of starting this iterative process of hearing from people, what do we need to be doing better, and then learning what people want to know about and going back to those communities with resources about what they've asked about. So sometimes there are things that people ask about that we actually do know something about. So we can use it as a kind of two-way conversation. We also developed our steering committee, which has people with lived experience on it, family members, leadership from human service agencies, some advocacy groups. As I mentioned, someone from Mass Health, some care providers. We have mental health care providers and physical health care providers on that steering committee. We met quarterly in year 1. We just met again last week. And then the other thing that we are starting to build is a relationship with another DMH-funded center, which people may be aware of at UMass Worcester, which is called the iSpark Center. And we're talking about how we can collaborate together and also how we can help one another. We also started a website. This is our new website. You have it in our packet. And we distributed the first quarterly e-newsletter. The kinds of topics we talked about on the newsletter one was about loneliness. And actually, Sandy Whitney-Sarles, who's going to present later, she wrote that synopsis. So she reviewed a research paper that was about loneliness and what put people at risk for loneliness. And very interestingly, actually, in that particular article, low levels of disclosure was one of the things that made people at risk for loneliness, people who weren't talking to other people about their psychiatric illness or other things. One of our other postdocs, one of her papers was in there about thinking about depression and emotional numbing and first episode psychosis. And again, it was another thing where people who weren't talking about it, people who were avoiding their emotion and keeping things in, were not doing as well. We also talked about marijuana and talked a little bit about disclosure, and we talked a bit about diet in that one. So this is something that you can sign up for. Many of you may have been asked when you came in whether you'd like to sign up for that. Please do if you're at all interested. What we're trying to do is share information and close this gap, and Dr. Freudenreich is taking a lead role on this newsletter. We're also hoping to feature a story of someone with lived experience, a recovery story of some sort in particular issues. So we're looking forward to this, and please, one way you can get involved is to sign up for that. We had, people were very prolific. They did a lot of publications and presentations. We did help create a statement of concern on marijuana policy, kind of fitting with what Dr. Holt was talking about earlier today, highlighting concern about use in youth, both the cognitive difficulties that seem to be resulting from even low uses of marijuana on the young brain, and this has to do too with the potency of what's available. Many people don't realize that marijuana today is not the same as marijuana 20 years ago. It's much more potent. And then the other, concern, which many people don't know about, which has to do with its risk for causing psychosis. It was really interesting because when I first read this statement of concern, I said, maybe we're wording this too strongly. I mean, we're saying that marijuana causes psychosis. Can we really say that marijuana causes psychosis? And one of the co-writers came back to me and said, well, smoking causes lung cancer, not in everybody, but we know it causes lung cancer, right? So it's the same thing. In order to say that something causes something, you don't have to say that it causes something in everyone. And that was very, eye-opening for me. So other things that we're talking a lot about is our pilot projects that we can expand. And Daphne presented on one of them today, this resilience enhancement. We looked too at homelessness was another kind of one of the vulnerable populations we were interested in. We're looking at length of stay and ultimate placement rates by race in the DMH homeless shelter system. And we just wrote that paper up, and it was really actually very interesting. There's a lot of work on health, and we did an exercise intervention, which Julia Brown will be a lead author on for people with early psychosis, where we had people go to the gym, sort of the same gym that MGH staff go to on campus, and we hired a personal trainer, and we had people participate in 11 weeks of high-intensity interval training. Our attendance rates were 75%. It was really good. People wanted to do this. And then there was a nutritional group, and we looked to see whether people improved their exercise, whether they improved their diets, whether they improved their motivation to exercise. We have a whole bunch of other kinds of studies going on. One of the exciting ones that we're hoping to resubmit, we didn't get funded for, but is a web-based family psychoeducation program, which maybe some of you have actually participated in as pilot individuals. NAMI was very helpful in having us recruit for this, and this is a collaboration with NERI, New England Research Institute, to really think about why don't we have more educational materials online for families? We know a lot about what to do with the first episode of Psychosis now, and why aren't we educating people and getting that out there? In a pilot project, what we found was that even among people who had already done NAMI, family to family, and were very involved and oftentimes leaders themselves, they showed improvements in terms of their own well-being, their own sense of burden. And what we think happened is that having this web link allowed those family members to send it to extended family members. So what they did was they bolstered their own support. So instead of it being, kind of staying within the nuclear family, all of a sudden there was something positive to show an aunt, an uncle, a cousin about what it means to have psychosis and what it means to recover from psychosis. So we're really excited about hopefully extending that work if we get funding. This is an example of the website here. We're going to try to do a lot in year 2. One of the big things we're working on is 2 things. One you're going to hear about is developing peer-led research. So once we develop these listening groups and we hear what people want, we wanted to develop some projects that flowed from that information. And you're going to hear from our wonderful team later on about how they're using that information. Excuse me. Another really big thing we're doing is trying to make coordinated specialty care for first episode available across Massachusetts. So DMH funded 5 programs in the Northeast region to get coordinated specialty care training, some of which we're providing through the center. So what we're doing is taking what's right now mostly in Boston and trying to move it out so that families everywhere, individuals everywhere can access this. And Margaret Geyer-Deason has been incredibly instrumental in thinking this is important and trying to change really the trajectory of psychosis and psychotic disorders by intervening early and well. These are the programs that we're working with right now in terms of training for first episode. So JRI, Elliott, Edinburgh, Boston Medical, and MapNet and DMH are helping support this. That MapNet is through BI Deaconess. So how you can get involved? Well, please sign up to receive our newsletter. Here's the link if you want to just sign up for it directly, or you could sign up outside, as I mentioned, with the table. We really want you to share your views and priorities as part of the same way we're doing listening groups across Massachusetts. I talked with Oliver and Daphne about, we want to hear from you guys about what are your priorities and interests. So I think there's some really good, thoughtful questions that relate to the content you're hearing today, as well as just hearing overall, what do you think we're doing well in this state? What could be better? And I think what's so exciting about having the center is we have maybe more audience with diverse stakeholders who could really make it, where hearing this information can really make a difference. We would love to have you at our annual conference that the center is putting on. The date has been set for April 10th. It will be at UMass Worcester. If you sign up for our newsletter and go to our website, you will see more details and know how to sign up. Or if you sign up for our mailing list, we will actually just send you an invite. So please feel free to do all of those things. And, thank you all for being here today. I can't tell you how meaningful it is for me to come here because I've been working here for a long time. I've had the incredible privilege of being a part of many people's lives in the audience in a small way, or maybe I like to think sometimes in a big way. When I hear about what's happening with your families, with the people that maybe I intersected with, it is incredibly gratifying. And I'm very grateful that you're here and to still be here myself. Thank you.